goal of the medical community is one fundamentally grounded in virtue, right? So that the medical practitioner is practicing medicine for the purpose of virtuously contributing to society, and you pick your favorite virtue, who cares, it doesn't really matter. One of the problems is, well, it's antithetical to the idea of autonomy because Bobby doesn't want to wear his helmet. I don't want you to tell me that I can't kill myself. I want to kill myself. And I don't want to do it because I don't know how to do it. I want to go to the professionals, and I want you to do it, right? The idea is that when we talk about autonomy and we talk about virtue-based ethic, there's a bit of a conflict between virtue-based ethics within the discourse of medical ethics and the idea, the concept, the first principle that I'm at least presenting with respect to medical ethics. What do? We just need to really acknowledge the tension. We're not here to resolve the tension, but as I said, and it should be like ridiculously obvious, Mommy wants Bobby to put on his helmet. Why does she want him to put on his helmet? Because it's good for Bobby. That is paternalistic. Bobby wants to be autonomous. Where you have paternalism and autonomy meet, you have conflict. Duh. Okay. Bored with that, moving on. Letter B. Contemporary medical ethics is more than an ethic of autonomy and less of a virtue-based ethic, right? So contemporary medical ethics is more of an ethic of autonomy and less of a virtue-based ethic. The idea is, in a contemporary discussion, in a contemporary analysis, we've moved away from the Aristotelian, now antiquated notion that medical practitioners are here to perform and to act virtuously, right? And I talked about this in the previous section. There's no correlation between the individual practitioner's act as an individual agent in the world, how he or she behaves in the world, and whether or not it affects, per se, their medical practice, the way in which they relate and treat their patients, right? There isn't really a need for, though we're not saying virtue isn't important, but there isn't a need to institutionalize virtue within contemporary medicine and in a discussion of contemporary medical ethics. Why? Because we've already acknowledged the patient's right to autonomy and thereby absorbed, acknowledged, accepted the corresponding duty to recognize and acknowledge the patient's right to self-determination and blah, 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 blah. Okay. See? Here's a direct quote. Competent adults have, this is brackets is my words, competent adults have the right to end their lives when they choose and to decline to participate in dangerous experiments. All right? We'll talk about this later with respect to patient experimentation. That's much later in the series. What we'll talk about more immediately in the future is, well, a few hours from now, is the idea that the patient also has the right to end his or her life. So the idea then, obviously, is we, within a social science analysis, a social science assessment of the medical community, and the ethic, the corresponding ethic, which the medical community absorbs effectively, need to recognize that the ethic is itself a consequence of a duty that the medical community has, in part, to acknowledge the patient's autonomy and thereby the patient's right to self-determination. Okay, so that's the first one, autonomy. Should be clear. Number 2, beneficence. One of the principles, foundational principles of, and also this is not to say that it is exhausting in any sense, right? This is one of 4, there could be many more. Ross talks about prima facie duties. You could incorporate some of those to a lesser extent here as well, but that's sort of off tangent. When we talk about beneficence, rather than it being patient-centered, obviously autonomy is patient-centered because the patient's autonomy is what's at stake. The patient's right to autonomy is what's at stake. Beneficence is physician-centered. S-I-C-I-A-N. excuse me, beneficence is physician-centered. Here's the direct quote from the text. Doing good to others, if an ethic of beneficence requires a physician to act in accordance with those means used to benefit a patient's health, then, by contrast, those means used to intentionally destroy, hamper, or suppress a patient's health are unethical. And what we have to note here is we are unconcerned with legality. We're talking about morality. Okay, when we talk about the notion of beneficence, then, we recognize that beneficence is more physician-centered. Why? Because as a physician in the medical community, what we are obligated with is making sure that whatever treatment we as the physician, if I can spell this right, we as the physician offer a treatment to the patient. Oh, my nose is itching like crazy. We as a physician offer treatment to the patient. Insofar as we offer this treatment to the patient, it is in our sort of obligation, in our duty to provide the best service to our patient, provide the best benefit to our patient, that this treatment benefit, right? And obviously the idea of benefiting is a bit ambiguous, it's a bit subjective, so we'll talk about this in a little bit. So I'll just read this quote one last time and then we'll move on. Doing good to others, which is what beneficence is, sort of generally speaking, doing good to others. If an ethic of beneficence requires this is a conditional, if an ethic of beneficence requires a physician to act in accordance with those means that are used to benefit a patient's health via treatment, then, obviously by contrast, those means that are intentionally used to destroy, hamper, suppress a patient's health are unethical. So that we look at beneficence as being the ethical obligation that the medical practitioner assumes. Maleficence is its antithetical concept, which I'm not going to introduce here because it's not discussed in the text at all. Let's just throw it out. So we have beneficence on the one hand in antithetical polemic relation to the idea of maleficence, which is doing bad, intentionally doing bad to harm. Maleficence obviously is an immoral act, whereas beneficence is not only a moral act, but it's one of the foundational principles of medical ethics as such. Okay, and I'm sort of moving through this quickly because I don't think it requires any more discussion or analysis than that. It should be rather clear. All right, so the first aspect of beneficence has to do with therapeutic experiments. Alright. In an analysis of therapeutic experiments, obviously these experiments are going to be human subject experiments, meaning that the experiments are based on assessing the, chemical, the effects of treatment, the neurological, the behavioral, susceptibility, adaptability to outside medical intervention. So the patient comes to the medical practitioner, says, "Hey, I'm not feeling good, blah blah blah. Can you check me out?" It's different from the physician saying, "Listen, we want to ask if you want to be part of an experiment where we're going to test some series of events for a greater generalized application to the population at large." I'll describe this in more detail in a bit. But with respect to human subject experimentation, it is specifically designed to benefit the patient's well-being, health, and so on. So I'll put designed to help / benefit designed to benefit patient. Where am I? Human subject experimentation specifically designed to benefit the patient's health, well-being. Here's the example. If the physician means to help this is a direct quote too. If the physician